So I'm going to talk about the allergy and hypersensitivity and its relationship in conjunctival disorders. That includes perennial conjunctivitis, vernal conjunctivitis, giant papillary conjunctivitis or GPC, and follicular keratoconjunctivitis. Actually, if we talk in terms of immunity, the immune system is an interacting set of the specialized cells and proteins designed to identify and destroy the foreign invaders or abnormal substances before they damage the body. So that is how the immune system works. So there is a sequence of cellular and molecular events that are designed to get rid of the host of an offending stimulus. It is actually a protective mechanism. Now, if this immune system fails, what happens? If the immune system fails, there can occur these three possible events. First, the hypersensitivity, which is an overactive immune response. The second is immunodeficiency, or there is ineffective immune response, or there can be an autoimmunity. That means the system is mistaken, that there is a mistaken recognition of the self-antigens, and that is called autoimmunity. So if the immune system fails, one of these three responses can develop. Now, what is hypersensitivity? This is a term used to describe the immune responses that cause the host tissue damage. There is a detrimental effect on the host, and there occurs fever, shock, inflammatory nature, spasm of the smooth muscles, gastrointestinal pulmonary disorders, and fatal circulatory collapse. So any of these effects can occur as a result of the hypersensitivity response to the cell immunity. Hypersensitivity is a state in which the introduction of an antigen into the body elicits an unduly severe immunological reaction. Unduly severe reaction can occur in four types or four forms. Anaphylaxis or atopy or type 1 reaction, as we commonly call it. The second can be cytotoxic or type 2 response. Third, there can be an immune complex formation, that is Arthur's type 3 reaction. And the fourth one is a delayed hypersensitivity reaction. We call it type 4. So these are the four types of the responses that we get as a hypersensitivity response. What is type 1? Type 1 is an exaggerated IgE response to the relatively harmless environmental antigens. Right. So we already know that there are some antigens that are floating in the air, and they are relatively innocuous, they are relatively harmless. Now, why an individual should respond to these antigens? There can be a genetic predisposition. The hypersensitivity manifests itself in the tissue reactions. That is occurring within 5 minutes after the antigen combines with the matching antibody. So there is an early response. It is exaggerated IgE response essentially. It results in the release of several active substances. There are pharmacologically active substances that includes histamine, slow reacting substances, and an eosinophil chemotactic factor within minutes. Also, there may be a second late phase in the same episode. The type 1 hypersensitivity is mediated through histamine, as I said, also prostaglandins, thromboxans, and cytokines. So hypersensitivity type 1 can be mediated through these pharmacologically active substances. Some of the examples of type 1 hypersensitivity include hay fever, atopic dermatitis, systemic anaphylaxis, atopic conjunctivitis, seasonal and perennial allergic conjunctivitis. All these are because of the allergic response to relatively harmless antigens. Type 2 is an antibody-mediated hypersensitivity against the self-cells or receptors on the membranes. So it is antibody-mediated hypersensitivity, but it is mediated by the immunoglobulin G and immunoglobulin N, contrasted to IgE in the type 1. It is the type 2 is mediated by IgG or IgM antibodies against tissue antigen, and that results in organ-specific antibody production. These antibodies bind to the cells or tissues and can cause local complement activation, the influx of the leukocytes, and tissue destruction. Examples of type 2 reaction are the Murren's ulcer, which we all know. It leads to the destruction of the peripheral corneal tissue. The hemolytic disease of the newborn, foot posture syndrome, hyperacute graft rejection, which occurs following peripheral are some of the examples of the type 2 hypersensitivity reaction. Type 3 occurs due to high levels of circulating soluble immune complexes, overwhelming the ability of the mononuclear phagocyte system to remove them. It is compromised, and that results into damage. It is caused by the antigen antibody complex that is getting deposited. These excess complex deposits in the various tissue and activate complement. Subsequent attempt by the neutrophils to remove them results in degranulation and tissue damage. Type 3 can take one of the two forms according to whether the immune complex develops in the circulating blood or in the tissue. There can be Arthus reaction, which is a local manifestation in the tissue, or there can be a serum sickness, which is the systemic form of type 3 hypersensitivity. So, one of the two forms depending on the underlying mechanism. Some of the examples of type 3 are the Arthus reaction, serum sickness, lupus, rheumatoid arthritis, etc. Immune ring formation of the cornea in the herpes simplex keratitis. The diagnosis of type 3 is demonstration of very low levels of the complements in the blood, especially C3 and C4, will clinch the rise of type 3 hypersensitivity reaction. Now, this is what I was talking about. The immune ring formation of the herpes simplex keratitis. It is an example of the type 3 hypersensitivity reaction. Type 4, there is no role. In type 4, there is no role of antibody or the complement. One aspect of cell-mediated immunity is being represented in type 4. Antigen activates specifically macrophages and sensitize T lymphocytes, leading to the secretion of the lymphokines. Due to the activity of the thymus-dependent lymphocytes or T lymphocytes, and clinically has a delayed onset. There are two types, tuberculin type and contact hypersensitivity type. So these are two varieties of the type 4 hypersensitivity response. Here are some of the examples of type 4 hypersensitivity reaction. There is corneal graft rejection, sympathetic ophthalmia, Vogt-Koyanagi-Hardal syndrome, optic neuritis, recurrent herpetic keratitis, bacterial, fungal, viral, protozoal, and parasitic infections, allergic dermatoconjunctivitis, disciform keratitis. And this is what exactly happens in immunity and a compromised immunity status or failed immunity status. There's a picture showing what is IgG, IgA, and they consist of heavy chains and the light chains as demonstrated here. And then there is a joining of these chains, the immunoglobulin N represented here, and there are the different bonds. So we already know that there are 5 types of the immunoglobulins: IgG, IgA, IgE, IgD, and IgM. And they all participate in one way or the other in the immune mechanisms. If you look at the light chain and the heavy chain as we elaborate or enlarge it further, this is the heavy chain, and in the head there is antigen binding site, right? This is the antigen binding site, and following this antigen binding, the subsequent chain of reactions start. There is a loop that binds antigen, which is located here. If I enlarge this area, this is the antigen binding site further, this is how it looks. And this is a loop that binds the antigen, and there is a variable domain of the light chain in this antigen binding site. Further, there are variable regions on the heavy chains as demonstrated here, and they all participate in the antigen antibody reaction. This is the antibody represented here, this is the antigen represented here, and this antigen antibody reaction occurring in the different forms as I discussed earlier in my presentation. This is an elaboration of the same mechanism. The immunoglobulin antibodies combines with the antigen, and that results into antigen antibody complex formation. It deposits in the tissue, it attracts complements, and then there is a reaction with the complement, which attracts neutrophils and the polymorph nucleolygocytes. That leads to inflammation, that liberates enzymes, cytokine, and may cause inflammation. So this whole phenomena occurs that it is initiated by the antibody combining with the antigen, and that antigen antibody complex initiate this sequence of events. Well, friend, let's move on to the allergic conjunctivitis. Allergic conjunctivitis is an inflammation of the conjunctiva due to allergic or hypersensitivity reaction, which may be immediate or delayed. And that is the response to the specific antigens. Now, these are the different types of the allergic conjunctivitis. It can be a chronic simple allergic conjunctivitis, or vernal keratoconjunctivitis, atopic, giant papillary conjunctivitis, flictannular keratoconjunctivitis, or contact dermatoconjunctivitis. So, as a prototype, let's have a look at what is simple allergic conjunctivitis. It is hay fever conjunctivitis, seasonal allergic conjunctivitis, or perennial allergic conjunctivitis, and acute allergic conjunctivitis. These are the different varieties. If you look at the perennial allergic conjunctivitis as one of the examples, then we find that it can occur at any age. There is history of personal or familial allergies. It is seen all the year round. It causes include animal dangers, insects, and the dust mites. So these are the different allergens that are going to produce allergic reaction in a genetically predisposed subject. The pathogenesis, allergens enter tear film. It comes in contact with the conjunctival mast cells that bear IgE antibodies. There occurs degranulation of the mast cells. Degranulation of the mast cells means release of the histamine, which promotes vasodilatation and edema. Symptoms and signs of the perennial conjunctivitis include itchy and watery eyes, burning sensations, and mild photophobia, mild to moderate conjunctival congestion and chemosis, mild hyperemia, mild papillary response, mild edema of the lids. All these are the features of allergic response of the conjunctiva. The treatment depends on the severity. Essentially, it includes elimination of the allergens if possible, cold compresses, NSAIDs, antihistaminics, which may be oral or topical, mast cell stabilizers such as sodium chromoglycate, topical corticosteroids, immunosuppressants, or cyclosporine for the steroid-resistant case or recalcitrant cases of the allergic conjunctivitis. This is a picture of the allergic conjunctivitis. You can see here marked edema or chemosis around the limbus and congestion of the conjunctiva. If you ask the patient to look down, we can see that the entire bulbar conjunctival in the upper part shows congestion, and there is a marked limbitis in this picture. The vernal keratoconjunctivitis or spring catarrh is another variety. It is a recurrent bilateral self-limiting allergic inflammation of the conjunctiva affecting children and young adults. It is more common in the males. It is an allergic disorder in which immunoglobulin E and cell-mediated immunism, cell-mediated immune mechanisms play an important role. So immunoglobulin E is important. 98% of the cases have bilateral disease. It can be asymmetrical. So one eye may be involved more than the other. There is intense ocular itching, lacrimation, photophobia, blepharospasm, blurred vision, foreign body sensations, burning and difficulty in opening of the eyes. There can be a thick mucus ropey discharge, xerotosis due to the large papillae. The giant papillae forms in the superior palpebral canal, which is the hallmark of the diagnosis in these cases. Papillae in the limbal area have a white chalky area at apex that is known as the Trantas spot or Horner Trantas spot. Peripheral neovascularization may occur. Tarsal papillae are seen in 83 to 84% of the VKC vernal keratoconjunctivitis patients. Bulbar papillae is relatively uncommon, seen in 70%. Both the forms are seen in 9 to 17% of the VKC patients, while cobblestone papillae are seen in about 16%. So it can be a palpebral variety, it can be a bulbar variety, it can be a mixed variety, and there can be a cobblestone papillae in some of the cases. The features also include pain if the cornea is involved. The corneal complications are quite common. It includes punctate erosions which coalesce and form painful micro erosions. Accumulation of inflammatory debris in the micro erosion prevents ready epithelialization of the cornea. And there is a non-epithelial lesion. The non-epithelial defects are produced and we call it shield ulcer. So this is how the progression of the vernal keratopathy occurs. The punctate epitheliopathy, epithelial microerosions, as you can see here, there is formation of a plaque, there is a shield ulcer, there is epithelial scarring, which can be seen by the left complication.